This is the Emergency Medical Minute.
All right, so good evening, everybody. So quick disclaimer is that this might not be a practical, practice-changing medical minute, but it's kind of based on an interesting study. So every so often we get walk-in or drive-in, drop-off trauma activations, stabbings, gunshot wounds, and they make for kind of like a whoa, all of a sudden, here's a patient who got shot in the chest and they get dropped off. So this happens, nationally. Some people refer to it as, homeboy ambulance, or it's always interesting when, yeah. So there was actually a study that looked at outcomes of patients that get brought in by EMS for penetrating trauma versus patients that get brought in by private vehicle. And this was not a randomized trial where they said, you have to drive yourself in today. We're not going to transport you. It was a retrospective look at a large database of over 100,000 penetrating trauma patients from across the United States at 100 large trauma centers. And they compared the mortality for the patients that had been brought in by EMS and patients that have been brought in by private vehicle, potentially to say, well, is there any benefit to coming in by EMS? So they found that the mortality for patients that got brought in by EMS was about 11%, whereas the mortality for patients that got brought in by private vehicle was 2%. So I don't think that you can make a conclusion that we should get rid of EMS and just have friends and family bring in trauma patients that get shot or stabbed. Probably it's lower acuity patients that, somebody says, I could probably take you in for this. I don't need to call an ambulance. But it does kind of lead to more questions about what EMS kind of does and what is beneficial and what might not be. A lot of people say, the best thing to do is just scoop and run. Penetrating trauma, get them to the hospital as soon as possible. Whereas some systems, they might put in, chest tubes in the field. They might do like needle decompressions of the chest. They might do more, and that might delay the time to patients get to the trauma center and get their definitive care. So it's kind of food for thought and kind of a, I think, somewhat goofy study, and that shouldn't apply, to change our practice, but interesting stuff. Any questions or comments? Thanks, guys.